Hello, everyone, and welcome to today's moderated panel discussion and live webinar on reducing harm in pediatric oncology, transparent conversations about cannabis for medical use. This webinar is brought to you today by the Canadian Collaborative for Childhood Cannabinoid Therapeutics, which is an academic research team based in Canada, along with our friends at MedCan Support. Before we get started, I wanted to introduce myself as the moderator for this panel today. My name is Dr. Lauren Kelly. I'm a pharmacologist and assistant professor at the University of Manitoba. I'm a mother to 2 toddlers and a first-generation academic. I come to this work with more than a decade of experience in maternal child drug safety research, and I wanted to start by acknowledging that my home is on Native land. I'm joining you today from Treaty 1 territory in central Canada, which is the homeland of the Anishinaabe, the Cree, the Ojibwe, the Dakota, and the Dene people, and the homeland of the Métis Nation. I'd also like to acknowledge that the water my family drinks is sourced from Shoal Lake. Our panelists and participants today are joining us from all over the world, and I'd like to invite each of you to learn more about the people who lived on the land before you, and to pay attention to the impact of the colonial systems that continue to oppress Indigenous and marginalized people where you live. You can learn more about the land that you live on at nativeland.ca. We would also like to acknowledge the funding that makes these webinars possible, provided by the Canadian Institutes for Health Research and the Canadian Cancer Society. What the next hour and a half are going to look like, we'll go over a brief introduction about why we're here, who C4T is, and what brought us to this discussion today. I'll be thrilled then to welcome everyone, including our panelists. This webinar is being recorded and it will be available on our website after today's session, which is medcankids.ca, and it will also be on our YouTube channel. You can share this webinar widely, and we do invite you to send us some questions. So we have a structured discussion, but we would love to hear from you. So if you have any questions for any of our panelists, there are many ways that you can send them to us. So you can send us questions on Twitter using the hashtags reducing harm or medical cannabis for kids. You can comment in the YouTube section directly on this video. You can also send us an email. Any questions can be emailed to c4t.canada@gmail.com, or you can send them on Slido with the hashtag reducing harm. C4T is an academic research team based here in Canada, and so I myself have the privilege and honor of serving as the scientific director for this team. There are more than 107 individuals that are members of C4T. Most of these are physicians and scientists based here in Canada, although we do have some international members. And we meet monthly to discuss ongoing research and advocacy efforts for medical cannabis in pediatrics. All of our members are required to disclose any potential financial conflicts of interest, and all of the information about our funding sources are available on our website. Again, that's medcankids.ca. And our mission is to conduct and share high-quality research on cannabis used for medical purposes in children, informed by patients, parents, healthcare providers, policymakers, and the scientific community. So C4T has been around since 2018, and we do research in a variety of different areas. So this includes things like parent interviews. We have a small tolerability or a small clinical trial looking at chronic pain in adolescents. We also have working groups that look at things like medical cannabis and school policies and the ethics of administering cannabinoids. And in 2020, we were awarded a CIHR Canadian Cancer Society team grant to study cannabinoids for symptom management in children with cancer. And when we started this journey, we thought we were just going to, find some products and test them and see if these products were safe and if they had any benefit for symptom management in children. And what we found very quickly was that medical cannabis space was complicated by not only the limited information and data that we had, but also complicated by different ethical questions and different historical and stigma that faces clinicians and parents when they're trying to make decisions about therapeutic use of cannabis in children with cancer. And so this led our team to initiate a variety of different research studies around ethics. This is one of our studies looking at the experiences of clinicians. And I'm just going to read out one of the quotes from one of the Canadian physicians that was included in that study, and it really kind of frames the discussion that we want to have today. It says, "Sometimes my patients feel as if they're really discriminated against, and that can emotionally affect them. And it can be really frustrating as a clinician because I'm trying to encourage medicine and I have people who don't understand medical training or expertise or knowledge protecting their own biases in it, which can indirectly impact my patient and their health. This also led C4T to produce a variety of advocacy work around the regulations for medical cannabis in Canada and how they can better protect pediatric patients. We have a variety of infographics on our website, so I'm not going to go over that data, although Dr. Oberoi will share some of it today. And we've also now submitted policy reports to the Standing Committee of Health and the Senate, as well as to the Health Canada during the Cannabis Act legislative review. And so why cannabis? Well, cannabis is a very complicated plant. It is available in many different forms. And there is a historical context, variable protections and legislation surrounding cannabis, some of which we're going to discuss today, and stigma that affects cannabis use, but also the willingness of parents to have discussions and report that they're using cannabis products. Cannabis is a complicated plant with more than 100 different active compounds, and we are still very much learning about how compounds like CBD work inside of our body to elicit some of the reported benefits. Just before we get started with our panelists, I thought we should just ensure that everyone is on the same page when we're using different language. So in terms of the kinds of cannabis products that are available here in Canada that might be available to a pediatric oncology patient or a child with cancer, include cannabis-based pharmaceuticals, medical cannabis, and recreational cannabis. So cannabis-based pharmaceuticals, these are products that have a drug identification number. They have undergone clinical trials, they have approved health indications, they're available by prescription, and they're produced to good manufacturing practices. In Canada, this includes drugs like Sativex or nabiximols in Europe and the UK, and Nabilone. Outside of Canada, this also includes a drug called Epidiolex, which is available in the UK, Europe, and the United States and Australia, and has been submitted here in Canada as well. Medical cannabis and recreational cannabis in Canada are both regulated under the Cannabis Act. Recreational cannabis is illegal for anyone under the age of 18 or 19 years, depending on what location you're in. And recreational cannabis is available in storefronts. So you can walk into a store and you can purchase recreational cannabis in Canada. However, medical cannabis is shipped directly from a producer to a patient. And so this requires a medical document from either a physician or a nurse practitioner. Either of those individuals in Canada can authorize medical cannabis for a pediatric patient. They are produced to good production practices, and there's a wide variety of products available. So this includes things like CBD only and CBD or cannabidiol enriched oils. And so why did we come together today? So we really feel, and this article it was actually in the news a few years ago about a woman who gave her son cannabis. And the main message was that this was done in secret and this saved his life and that she was, ashamed to talk about it. And we don't feel that talking about cannabis should be a secret. And so today what we really wanted to do is bring together some different voices, some parents and clinicians from here in Canada and the UK to discuss cannabis use in children with cancer. And so I'm thrilled to introduce today's panelists. I will do my best to review their very extensive qualifications, and then I'll ask each speaker to join me on stage, say hello, and we'll have a little icebreaker. Maybe I'll ask what the best and worst meal you ate last week was. So our first panelist to introduce today is Dr. Sapna Oberoi. Dr. Oberoi is an assistant professor in the Department of Pediatrics and Child Health at the University of Manitoba and a pediatric hematologist oncologist at Cancer Care Manitoba. Her research focuses on symptom management and supportive care of children and young adults with cancer in order to improve their overall outcomes and quality of life during and after cancer treatment. Welcome, Sapna.
Hi, everyone. I'm happy to be here.
So what was the best thing you ate last week?
Well, the best thing I think I ate was guacamole, which my aunt made for me. So that was delicious. Well, the worst thing, I would say everything I made for myself.
Well, I'm sorry to hear that, but welcome and thanks for joining us today.
Okay. Thanks.
Our next panelist is Dr. Dani Gordon. Dani is a double board certified integrative medicine physician and leading expert in integrated and cannabinoid medicine and resilience. She's treated thousands of patients with medical cannabis and is the vice chair of the UK Medical Cannabis Clinicians Society. She's also authored a book entitled The CBD Bible. She's the founder and medical director of the Resilience Clinic, her UK-based medical cannabis practice and well-being platform with a focus on mental health, chronic fatigue, and complex chronic diseases. Welcome, Dr. Gordon.
Oh, now I can hear you.
Great.
Hello.
Hello.
Thank you. It's nice to be here.
So you want to tell us what was the best and worst thing you ate last week?
Oh, well, we went out and had some lovely Korean soup last week, and that was amazing. And I have to agree with Sapna, pretty much everything I make for myself.
You are all, everyone is very busy, but soup always tastes better when someone else makes it. It's just a lot of work in my opinion.
Absolutely.
Great. Our next panelist is Matt Hughes. Matt Hughes is the co-founder and director of MedCan Support, a hub for education, advocacy, research, and support in the use of prescribed cannabis in pediatrics. Matt has been involved in the UK medical cannabis sector since early 2019 when his son Charlie was prescribed cannabis in the treatment of his severe treatment-resistant epilepsy. Charlie has seen a dramatic improvement in reduction in seizures and much improved quality of life since starting cannabis. And Matt continues to campaign and advocate for population-wide NHS access for children suffering from severe epilepsy and to be a voice for patients and families within the growing private cannabis sector, joining the executive committee of the UK Cannabis Industry Council. Welcome to the stage, Matt.
Hello, thank you.
And same question that I asked Dani and Sapna. What's the best and worst thing you ate last week?
I want to go opposite to what Dani and Sapna have already said. Best was a home-cooked meal by my wife, and the worst was a McDonald's.
Fair.
So, yeah.
At least it's a consistent level of McDonald's expectations. Great, thanks, Matt, and welcome. Thanks for joining us today. Our next panelist is Dr. Rod Rassekh, and Rod is a pediatric oncologist at the BC Children's Hospital and a clinical associate professor in the Division of Hematology, Oncology, and BMT within the Department of Pediatrics at the University of British Columbia. His research focuses on the treatment and long-term outcomes of children treated for cancer and conducting studies that will lead to scientifically based guidance on medical cannabis use for pediatric patients and their families. Hello, Rod. Welcome.
Hi, Lauren. Great to see you.
You as well. Same question.
So best meal. I love a good steak. And I had one of my long-term leukemia survivors who lives on a farm brought me steaks from kind of their farm. And my wife cooked it. And it was absolutely the best meal I've had in a very long time. Worst is my Thursday lunches are always my worst because it's a very busy clinic. So literally I scrounge whatever is in the kind of on the desks that we have. So it's usually leftover Halloween candy. So I think I had a little coffee crisp bar, and that's all I had on Thursday.
Well, I'm glad to hear about your steak because that sounds much like a very important highlight of the week next to your candy bar lunch. All right, great. Thanks. And Tracy, next to the stage is Tracy Brace. As a registered psychiatric nurse, Tracy has dedicated her career to supporting and walking with individuals on their healing journeys from concurrent mental health and substance use disorders. Her clinical practice is enriched with a deep awareness of cultural safety and trauma-informed care. As a parent, Tracy's journey with the health system began when her son was born premature, and they had a 4-month stay in the NICU. At 2.5 years old, her son was diagnosed with a brain tumor, and she found herself advocating for medical cannabis use for her son. Tracy's interests naturally aligned with family-centered care as she found that conversations between healthcare professionals and parents about medical cannabis can be very challenging. As an educator, Tracy aspires to integrate her lived experience, compassion, and clinical curiosity to disseminate education to healthcare professionals and assist in cannabis policy development for pediatric patients. Thanks for joining us today, Tracy. Same questions to you. How did you eat last week?
Well, for me, cooking breakfast never fails me. And I have a baked oatmeal recipe that I love that has peanut butter in it, and it uses up all my freezer bananas, which is fabulous. And I can eat it on the fly, in the car, on the way driving to school. So that would be my favorite meal because it never fails. And I always have it ready. And I tried to make a really nice steak meal this week. And the steak was great, but I burnt all the garlic and the onions that were in with the roasted potatoes. So that kind of trashed that. And I forgot and overcooked the green beans on the stovetop. So just kind of like pushed that stuff around the plate and enjoyed the steak.
Well, it made it to the plate, right? That's the first part. Great. Thanks, Tracy, for joining us today. And our final panelist, we're thrilled to welcome Dr. Bob Phillips. Dr. Phillips is a senior lecturer at the Center for Reviews and Dissemination at the Hall York Medical School at the University of York, and an honorary consultant in pediatric oncology at the Leeds Children's Hospital. He's the lead of the PICNIC collaboration, or Predicting Infectious Complications in Children with Cancer, and which was formed by engaging international clinical and methodological experts, parent representatives, and healthcare researchers to investigate primary patterns of risk in febrile neutropenia. Dr. Phillips' work supports methodological improvement in individual patient data, meta-analysis, and in improving outcomes in cancer medicine, capacity building, and translation of research in the NHS. Welcome, Bob.
Thank you very much. I had fish and chips with mushy peas from the local chippy, which in translation is thick French fries with battered haddock and marrowfat peas that have been cooked very thoroughly to be a bit squishy with extra vinegar and salt on them.
Now, was that the good or the bad meal?
That was the good. That's the good meal. That's amazing stuff. The bad meal was a hospital sandwich at 9:30 at night after I'd arrived at 8:30 in the morning.
Fair.
But a hospital sandwich at any time, actually, is probably going to be the worst meal of your week.
Very fair. Well, thank you for joining us today, and welcome everyone. Before we get into the live questions, first we wanted, Sapna, you've done some really great work and some research here in Canada, gathering perspectives of pediatric oncologists and patients here in Canada. So I'm just going to ask and turn the stage over to you for a few minutes just to share a little bit of some of the results of this work. So over to you, Sapna.
Thank you, Lauren. Thanks everyone for coming and joining this webinar today. So in next couple of slides, I will show that what we have done in last few years. We wanted to see the perspectives of pediatric oncologists, pediatric palliative care physicians, and also of some of the patients which are using cannabis. And some of this data is actually coming nationally from Canada, whereas some was only done locally in a province of Manitoba, which is located in the center of the Canada. So we all know, and that's why I think we all are here, that there has been increased use of cannabis for symptom control and also for having some anti-cancer effects among children with cancer. And that has been the trend for last couple of years. And there was actually, prior to our study, a study was done by US investigators, and they found that 30% of the providers in pediatric oncology, they received more than one request for cannabis in previous 1 month of their practice, which just shows that how frequently as physicians and practitioners we are facing requests and questions about what's the role of medical cannabis for pediatric oncology population. We also know that from the literature coming worldwide, and some from Israel and some from Canada and other countries as well, that there is some evidence. Again, it's not from randomized controlled trials, but most of these studies are cross-sectional studies or some case reports or real-world data, which shows that patients who have been using cannabis in pediatric oncology, they report some improvement in nausea, vomiting, reduced improvement in their appetite, pain, and anxiety. But along with the improvements, we also see that these reports also highlight some of the side effects, such as somnolence, pain in the throat, diarrhea, vomiting, red eyes. So those symptoms are also common. Next slide, please. So what we wanted to do, or what's happening in Canada, so we surveyed pediatric oncologists and pediatric palliative care physicians within Canada, and the survey was done in 2020, and we have around 250 practitioners, so we kind of captured around half of them. So this is just a highlights of the survey which we did. So 92% of the pediatric oncologists and pediatric palliative care physicians provided care to at least one child using cannabis for symptom management within last 6 months when the survey was conducted. And 57% provided care to at least one child using cannabis as an adjuvant anti-cancer agent. So majority of them were using for symptom control, but half of them also provided care to the children who were using it as an anti-cancer agent. And when we asked physicians how they perceive the benefits of cannabis to be in, so this bar chart here kind of shows, the green shows that the physicians perceived cannabis to be moderate to highly effective, orange shows minimally effective, and blue is not effective, and red is I don't know. So here we can see that a majority perceived that cannabis potentially has some role in treating nausea and vomiting, chronic pain, and cachexia related to related to cancer. Whereas I think contrastingly, most of the physicians, I would say not most, nearly all expressed that they don't think that cannabis has an anti-cancer effect. Only one physician said yes, but the rest said not effective, or they don't know. Next slide, please. And then we also wanted to gather their perspectives, what they thought about the value of cannabis as an adjunct while the patient's getting curative treatment, or those getting palliative care, or those who have done their cancer treatment and now are the survivors. And 90% of them said that it's probably valuable in a palliative care setup because of because of providing symptom control. 80% said that it possibly has some value in the curative treatment as well. Again, mainly related to the symptom control, which results from our treatments. But only 20% said that survivors should be using it, which kind of shows that now we have done the treatment and hopefully we don't have those symptoms such as chronic pain, nausea, and vomiting in this population. Although overwhelmingly, although most of the physicians, as we saw, valued the benefit of cannabis, but also they had a lot of concerns because some of these benefits are seen in real world in their clinics, but has not been proven by randomized controlled trials. They're still worried about uncertainty of the side effects, concern about misuse, abuse, dosing in children remains unknown, and uncertainty about the quality of products because we can authorize cannabis, but we still cannot prescribe. It doesn't have a drug identification numbers in Canada, and we don't have a dosing guidelines. And there are also lack of child-friendly formulations. So I think those are the major barriers physicians mentioned, which kind of prohibits them from even authorizing cannabis to this population. Next slide, please. And all of them actually valued the importance of doing research on cannabis products, especially for symptom management. These green bar represents their interest in doing a clinical trial for symptom management, whereas the yellow was to explore the anti-cancer effect. So the enthusiasm for evaluating the anti-cancer effect was less as compared to evaluating it for symptom management. Next slide. So this survey was done again by our group, was led by one of my colleagues, Dr. Stacy Chapman, and this was done in province of Manitoba only. So it was a cross-sectional survey of the patients who were getting treatment in our center. So the number of respondents were 64, and 22% reported some kind of cannabis use, either for symptom control or for other reasons such as anti-cancer effect, depression, panic attack, anxiety, sleep, appetite, pain. And if we see approximately 1/3 of the patients were not getting cancer treatment when they were using cannabis, whereas 2/3 were getting active cancer treatment. And the forms of cannabis they used varied from oil edibles to inhalation. And of the 14 patients who reported the use of cannabis, all of them reported improvement in symptoms. Other important thing, I think, which the survey highlighted was the monthly expenditure which a patient had to pay. Their families had to pay for accessing cannabis, and it varied from $50 to $500 Canadian dollars, which is a lot of out-of-pocket expenses which families are still paying for using cannabis as an adjunct to the treatment. Next slide, please. So I think the key messages from our Canadian data from these two surveys is that 92% of the pediatric oncologists and palliative care physicians are providing care to the patients who are actually taking cannabis for symptom management while their treatment for cancer. All physicians want to enhance their knowledge and obviously want to participate in research exploring cannabis for symptom control. And among the children with cancer, we found that at least 1/5 are still in our province for using cannabis. And again, that varies province by province. But from our C4T group, we know that it's happening all over Canada. This probably reflects the national numbers, and there's a plan to do a national survey as well.
Yeah, that's great. Thank you so much, Sapna. I'm just going to ask Rod if there's anything else you wanted to add about the Canadian experience. I'm just going to make the slides go away now so that we can have a discussion up here. So yeah, Rod, anything you wanted to add before we seek some external perspectives here?
Yeah, I think both the paper Sapna showed really captures what we're seeing. Is I think more and more families are asking about it, using cannabis, both for symptoms as well as, I think the group that certainly has been the one I've seen the most involved is the brain tumor world, where I think that's probably the highest rates of use, probably due to poor prognosis of some of those tumors, where we're doing a great job curing many kids with cancer, but it's those harder to treat cancers that parents are quite appropriately trying to find anything that can help their child, both from a symptom control point of view, because they are often the brain tumors, the ones that are more symptomatic from their tumors, but also from desperately trying to find a cure for their child.
Yeah, thanks, Rod. Dani, maybe you can start by just telling us a little bit about what kinds of cannabis therapeutics are currently available in the UK. And then maybe we'll go to Bob next to talk about the oncology perspective. But yeah, so tell us, Dani, what's available in terms of cannabis products in the UK currently?
Yeah, so I treat adults in the UK in my practice here. But for the product selection, we have a pretty good selection of cannabis oils that are now available for patients, adult patients primarily at the moment. And we have what's called cannabis flower, which are basically dried herbal cannabis that you can put into a vaporizer, again, for adult use. And then we also have the licensed products, Sativex, Epidiolex, but oftentimes we're actually preferring to use the full spectrum extracts because patients report better effect than using Sativex or Epidiolex, for example, in the respective patient populations that would use those medications, such as in epilepsy with Epidiolex and such as with MS spasticity when it comes to Sativex, which is the licensed indication for Sativex. So we're still having trouble with maintaining good supplies here in the UK. There's, always, I've had a few patients this week where they didn't really like one of the products, for example, and we wanted to change to a similar product, similar amount of CBD and THC, but from a different cultivar, a different strain, if you will, of cannabis. And sometimes that's difficult, unlike in Canada where I had lots of choice. We're still having trouble with that breadth of choice. And also the quality of products tends to vary and the price tends to vary. So some of the cheaper flower products, for example, some patients find them effective, but many patients are not happy with them. There's been a few recalls for mold, which is absolutely so concerning, especially for any oncology patients. Usually, I stay away from flower for oncology patients for this reason, but sometimes they can't tolerate anything by mouth. And of course, giving someone a moldy product when their immune system is already compromised is very dangerous. So those are some of the issues that we're facing currently, but things are improving slowly.
And so when you say a bunch of products, does that mean that there are, high CBD oils and low CBD oils and balanced products? Like there's a variety of different sort of ratios of components?
That's correct. Yes. So in medical cannabis, we really prescribe based on CBD and THC content, even though most of us who've been working in medical cannabis for quite a while acknowledge that you can have the same amount of CBD and THC in a product from a different cultivar, a different strain of the plant, if you will, and it may have a different effect, especially on certain patients, especially with mental health, for example. However, we have to dose primarily based on CBD and THC. So yes, we have the high CBD oils, a 20-to-1 ratio of CBD to THC. Then we have a few that are kind of in between. We have balanced ratio products, and then we have high THC products, which, you know, usually around 20 milligrams of THC per mil and about 1 milligram of CBD per mil. And what we would choose for a patient depends on many, many factors, including their indications, any caution areas, their mental health history, and obviously what they're trying to do with it. THC, of course, being more helpful for things like sleep, pain, muscle spasm, this sort of thing, and then CBD being better for daytime use and more mental health indications in some patients.
Yeah, and that's great. And I know you primarily are caring for adults, and so maybe Bob, I'll turn it over to you and just ask a little bit about, in the pediatric population that you're caring for in the UK, are you seeing the same kinds of cannabis use that's sort of been echoed by our Canadian oncologists here? Can you speak to a little bit about what the landscape looks like for the pediatric oncology patients that might be looking to or interested in cannabis use in the UK?
Yeah, sure. I'm a complete ringer in this. I'm not a specialist clinician on a list of cannabis prescribers. I've not prescribed cannabis in flower, rose, weed, anything. I've prescribed Nabalone, and I've been involved with the prescription of Epidiolex. And I've failed to get involved with trials, which then were going to be all age and then turned into an adult trial during its evolution. I get asked about cannabis products every now and then, and like Rod says, primarily from the patients who are relapsed or who have essentially palliative diagnoses. And I am smack bang in your, I haven't a clue if it works for cancer or not because the trials haven't been done. But I can tell you that for the refractory nausea and vomiting, particularly the teenagers, give them some Nabalone a couple of days before, let them take it through. They eat better, they puke less, they turn up on time, they don't talk much and sleep more, which is always a great thing when you've got teenage patients stuck in hospital. It's a very, very different sort of experience that I'm having than your Canadian physicians and your specialist cannabis prescribing physicians. I've got no real connection with this beyond being someone that wants to investigate how we do stuff and how we make stuff better. My other hat, and I actually do have a hat on the wall that I will put on if needed, is in the chair of the Drugs and Therapeutics Committee.
That hat.
And in that role, I sit and work with a group of people to decide which products may or may not be prescribed within our hospital environment, which we have to demonstrate safety and efficacy and a funding stream. And safety actually means, can we get the same product for the same length of time? And so if you've got something with a very fragile sort of way into the country, then it can be very difficult for a hospital to say, yeah, let's use this. We might get it for a month and you're planning to use it for the next 6 years, but it might not be available. That's true of all drugs. I'm not going to say that this is cannabis related because it's true of all drugs in a sense, but we ask that question of all of them, along with, can you bring of evidence of safety? Can you bring of evidence of efficacy? And particularly within pediatrics, can you bring us dosing regimes that work for a variety of sizes of patient? And without that information, you are not going to get it out of our hospital. That's not to say you can't get it on private prescription. That's not to say you can't get it through other routes in the UK. But within that NHS and within that framework, there's a great deal of actually comparative equity within there, but based around those rules. And what we need is decent quality evidence. It doesn't have to be from the UK, but it has to be decent quality evidence to back up some of these things that people want it to work for and are using it for in different ways.
Yeah.
I was just going to say, although I don't treat children, I have actually seen in the last 2 days 2 young patients with quite bad cancers who were 20. So, just kind of over the pediatric mark. And, echoing what Rod was saying, actually, they're coming to me because it's palliative brain cancers. And one was a sarcoma that went to the brain, another one's primary brain cancer. So, of course, they're not coming to me to forego medical treatment. They just want to know, hey, can this help? Yeah, can this help reduce side effects, symptoms? And it's a really difficult conversation to have with patients, especially, I'm having these conversations with, informed consent with their parents oftentimes, because the kids, I shouldn't say kids, but these young adults are so sick. And it's very difficult because what I have to tell them is that, cannabinoids have a lot of anti-tumor effect in petri dishes, in animal models, and in some preliminary studies as a chemoadjuvant, in a very specific brain cancer. But beyond that, we actually don't know. So if someone's palliative and they're stage 4 and they've tried everything, and one of the patients I saw today, they had just been told, you're out of options, sorry. So they're going to Germany for, dendritic cell therapy and really kind of avant-garde stuff. So this is the patient who I'd say, look, we don't know, but it's probably not going to hurt at this point. And if it makes you more comfortable, let's just add it I can't prescribe for an anti-cancer effect because the GMC wouldn't really like that. But, we just can't do that yet. We just don't have enough information, but I would prescribe for palliation of symptoms. And it's fraught with difficulty. Parents, they always want to get an answer out of me. Well, but yes, but okay, well, in this tumor type, what do you think? Like, what do you really think? I don't know. And it's awful. It's awful to have to say that because, of course, a lot of times, these families, they've been told by patient advocates, well-meaning people in the UK, some of whose children have used cannabis in cancers that were stage 4, and they did hit the jackpot and it worked. And these patients had miraculous recovery. So now some of these people have, networks, and they've reached out to the families that I see, and they say, oh, this is a cure. So this is what they're hearing before they get to me. And this is like your last hope. So it's very hard.
For sure. I was just going to say, you brought up a topic that leads nicely into the next question, which is around the parents' perspective and I was hoping maybe, Tracy, you could speak to just sort of your perspective. Like, how do you navigate this healthcare system when the doctors that you're going to for expertise are telling you, well, we don't know? Maybe you can talk a little bit about what your experience was like being on the other side of that.
Yeah, Lauren, I can. Well, my experience while I was living it, it's quite a different story than the narrative I have now. I've had several years now to reflect on our experience. And during this time, I've been a part of many conversations with the diverse members of C4T. So to give a sense of what our experience was like, I've done my best to thread these two narratives together. As a parent, navigating the traditional healthcare landscape has been quite challenging in general. And then advocating for cannabis, a therapy well outside the status quo, became even more challenging. There were hoops to jump through. The process wasn't straightforward at all. And it certainly felt like things were made harder than they needed to be. Right from the get-go, I was open about my curiosity about using cannabis to treat or slow the progression of my son's brain tumor. But he was only 2.5 years old at the time that he was diagnosed, and we were only just learning how to process what his diagnosis even meant, and so we agreed to hold off. Like any parent, when their entire world becomes turned upside down, I struggled with being told that for now we just needed to watch and wait, especially with discussions surrounding cannabis potentially having anti-cancer properties. When I would read about cannabis, the prospective idea of using it gave me hope, and I just wanted to feel like we were doing something to fight this disease. I decided because of his age and the unknown risks, we would wait. And we would only use cannabis if he required it for symptom management, should he wind up needing chemotherapy. My son's disease didn't behave as anticipated, and by the time he was 3.5 years old, he started chemotherapy. Surprisingly, the effects were mild and his symptoms were able to be managed with conventional medications. Although I still wondered to myself, what if? What if we had started cannabis right away? Would he even be needing chemotherapy right now? Well, on his second type of chemotherapy, the side effects began to profoundly affect my son's quality of life. As a direct result, the quality of life for our whole family was impacted. We felt helpless and we were sick and tired of him being sick and tired. Adding additional conventional medications felt counterintuitive, as many of them are very sedating, and we wanted our son to be alert, engaged, and to thrive. The unknown risks associated with medical cannabis seemed negligible to us at the time when we were watching our child suffer right now. At this time when this was happening, cannabis was not yet legal for recreational use in Canada, and I really wanted to ensure we had continued access to good quality products. Feeling like I was some sort of detective, I began to hunt down information on how to obtain medical authorization for a child. Searching for this information felt covert and lonely, but I questioned the validity of a lot of the peer-to-peer knowledge exchange forums that I was finding online, and I really longed for scientific information. I kept searching for evidence-based research. What I was trying to accomplish was making sure I'd done as much of my own homework as possible before I requested a referral for medical authorization. For example, to who and where was I even requesting this referral to or from? In the meantime, from what we felt was a reliable source, we began treating our son with cannabis tinctures to manage his symptoms. I felt uncomfortable that I'd already begun providing it to my son without full disclosure to his treating oncologist. Upon reflection, I think I just needed to know for myself first. I just really didn't want to put myself out there advocating for something laden with so much stigma if it wasn't even going to help him. But it helped. It helped a lot. When we did have the conversation, it went as I expected it to. We also approached our pediatrician and GP to have the same challenging conversation go a similar way. But our decision was already made, and I wanted it to be respected. But as a healthcare provider myself, I was equally as aware that I wanted to give that same respect towards the comfort level of the providers to decline, so I didn't push it. Already overwhelmed with the uncertainty regarding my son's health, I found myself stuck at a fork in a road between what I believed, what his healthcare providers felt was best, and what my intuition was telling me was the best thing to do. We carried on providing the tinctures we had until we were able to obtain a signed referral to see a physician in a private clinic who then provided us with the medical authorization. The difficulty as a parent is in order to gain access to a safe supply of medical grade cannabis and in order to apply your receipts as medical expenses on your taxes here in Canada, you need the medical authorizations. Physicians then become the gatekeepers to your access. Through this process, I learned there isn't just a lack of guidance for parents, there's also a lack of guidance for the physicians. Due to the lack of research, especially specific to pediatrics, we're in a position right now where we're all having to learn how to navigate this together. That's really the problem with the way things are set up now. Even if you are able to obtain medical authorization like we did, without the research, every child is becoming their own experiment, and there's many trials of one child going on right now. Through our journey, we learned how important it is not to take system-related issues personally. Even just over the last few years, we've seen gradual changes, but it takes a really long time for systems to make changes. Over time, with where we're at now, after overcoming numerous bumps and hurdles on our path, further disease progression, a total of 8 neurosurgeries and 4 chemotherapy protocols, the what ifs that initially plagued me about my hesitation to use higher doses of cannabis as a form of anti-cancer treatment have now turned into even ifs. Because even if this plant is showing a lot of promise in some areas of oncology right now, without the research, none of us really knows.
And your point about that every kid is their own clinical trial right now gets me in all the fields, because that's, one of the biggest challenges is that there is no research, but there's no infrastructure for research. And, we don't even track here in Canada. They can't tell me how many medical authorizations are for patients under the age of 18, because the way that the systems have been built is that data goes to the licensed producers, and then nobody collects data and follows up on it. So thank you for sharing that story and your experiences, Tracy. It's super valuable. And I wondered, Matt, if you wanted to maybe chime in a little bit about, I know obviously you're coming from an epilepsy perspective versus oncology. And do you think the discussion where, epilepsy, where there are some clinical trials, do you think that the discussion around cannabis with epilepsy is a little bit different? Or maybe you can speak to a little bit of your perspectives there and what you've heard from some of the oncology families that come through MedCan.
Yeah, it's basically what Bob was saying earlier. With regards to cancer, it's patient-driven. It's, what we're hearing is from mums and dads and from carers giving cannabis to their children, and, anecdote evidence from their experiences. Epilepsy, we do have clinical trials. We do have clinical data. We do have clinicians supporting that and prescribing and collecting data. So that's the primary difference, I think, from a clinical perspective. We know cannabis is useful in seizure control. In cancer, it's very much, it's different cancers. No one really knows the dosing, and it's very much patient-driven. So that's the primary difference here, especially here in the UK.
Yeah, and I think that makes a little bit of physician comfort, but I'm sure it's a little bit more comfortable when there is some clinical trials to look back at. I wanted to go back to one thing I think, Bob, you mentioned around sitting on the Drugs and Therapeutics Hospital Board. And I know, Rod, you had some experiences with in-hospital cannabis prescribing. I wondered if you could talk maybe a little bit about how that went for you, and some of the challenges and successes, and maybe lessons learned about developing policies for pediatric in-hospital cannabis management, let's say.
Yeah, well, my interest actually came out of toxicity that we saw in 2 patients who were doing it in secret. And so we had 2 patients who had heard from other families that cannabis had anti-cancer effects. These were hard to treat cancers. And so they took an oil that was produced in a garage we're talking 12 years ago, before legalization. And they basically took the oil, gave the dose that they were cannabis naive kids, but basically they took the dose that basically their neighbor in the Ronald McDonald House they're staying at told them that their kid was on, but that patient had ramped themselves up. And so basically these kids took 2 doses, each took doses, and they ended up with blood pressures that crashed. They ended up in ICU. We thought they were in septic shock, but in fact, it was only after the fact the parents kind of, and again, it comes down to what Tracy said, the stigma. They didn't actually initially want to say, actually, I just gave my child this dose of something that's illegal and bad. And so essentially we had 2 kids who both did fine. They pulled out of it. We were able to get them, give them fluids, and they came up. But that really got me thinking and starting asking how many other kids are on it and or want to be on it, etc. And so we had to go to our hospital, and when we started asking, lots were either going to be using it or were already on it, and just nobody had asked them because of that stigma. And so because of those 2 cases, we actually went to our hospital and said, listen, this is happening in the shadows, and there's drug interactions, there's safety concerns we may not know about, there may be side effects we're not documenting, there may be benefits that we're not documenting, it's both ways. And so we basically said we have to do this in the open. We have to make, take away that stigma and say, to allow families, if they're going to do it in the open and let their oncologists know. And so our hospital had a policy. It was, you could not give medical or any cannabis to patients on site. And I live in an area in Vancouver has always been the most liberal with regards to cannabis use. And so I didn't think the hospital would go for it initially, but we involved our hospital ethicist, we involved lots of clinicians in that discussion, and even hospital lawyers got involved of how can we actually do this in a harm reduction model. Lots of barriers. We had to come up with documents that parents would sign that said, we were not condoning medical cannabis when you wanted to use it in hospital. But we were able to actually change policies, which took a while. But really it had to, the voice had to come from parents to say they wanted this. And that uncomfortableness for us as physicians, where we, as you heard, we don't know how to dose. We don't know if it's safe. We don't know the long-term outcomes of this in a 2-year-old brain if you go on it for a prolonged period. of time. And so we had to have those discussions. And so ultimately, I kind of became the point person for families, you know. And again, not all, I think you heard it from Tracy, not all oncologists were on board with this. Actually, you know, there was pushback saying we don't know this drug. We shouldn't be allowing this. So there, you know, even with colleagues in my own department, we had conflicting views of how we should proceed in that, especially in those early days where there was even more stigma around it than now, where people are starting to say we should research it. We need to find dosing. We need to find safety. So.
And we've been hearing about this call for research and call for more data. So I just wanted, and I know Bob, you have to head off a little bit early today, but I just wanted to talk about, you know, in oncology, there's lots of networks that exist to study all kinds of different drugs and all kinds of clinical trials and new therapeutics. And so maybe can we talk a little bit about what are is there a way that we can build medical cannabis research into these sort of existing pediatric cancer networks? Is there an opportunity here that we can do some pharmacovigilance? What are your thoughts on that?
Yeah, thank you. I think pediatric oncology, TOA oncology is probably the best setup of most of the major pediatric medical specialties in terms of the way that research works and long-term research works. Sorry. Many people on the other side of this webinar, and certainly on this panel, will know that peds oncology really grew out of research, all of that sort of thing, going forwards. And so we've always led with trials, with national trials, with continental trials, with global trials, to take things forward, and particularly when it comes to the anti-cancer agents we have, a bit less so when it comes to supportive care, nausea and vomiting, febrile neutropenia and stuff. There's an established network across Europe for the examination in early phase trials, phase 1-2 trials, to see in phase 1, what doses should we use, what toxicities are we seeing, phase 2, does using what appears to be a maximum tolerated dose make a difference to the pictures? Does it change the scans? Does it change what levels we see of the cancer in the blood if it's a leukemia? So looking not at whether it really benefits the patient in the long term, but does it make a potential difference by changing what we can see in the short term? That's a phase 2 study. And then it goes on, and those that look optimistic are usually put alongside or in addition to our standard agents for different treatments and different tumor types, often with bolt-on biological studies to say which of these that responded, why can we understand the science in it as well, and that then developing and going forwards. Now, to give you an idea about that sort of phase 1 onwards product, and there might be 200 compounds get tested at that early phase, that phase 1 stage, of which maybe 10 of them go through to the phase 2 stage. And then of that, maybe one out of that 200 actually goes on to prove a real benefit going on. Small numbers, but most of them have got great effectiveness in the Petri dish. They help the mouse that you gave an artificial cancer to get over it. But it's only when we put it into the real situation of incredibly complex children's cancers do we see whether it really makes a difference or not. That network exists, and cannabis and cannabis products, if they have that same sort of backup and going forwards, not just what I bought off the bloke who's got a very warm garage down the road, but actual medical stuff, that can be plugged into that same network, and we can use that network to advance things in the areas that it looks like it's going to be most beneficial. So particular types of brain tumor, for example, where we've got the biology that suggests this might make a difference, we can plug it into the supportive care network to say, well, we knew that Nabalone works with some kids in some settings in nausea and vomiting. Can we use it for different things in different ways? Can we use that supportive care network to get those trials going? Because now we do have the legislation and we do have the ability to do that. It will be a lot of hassle, but every trial is. But that's a possibility. Just think about
I was going to say, actually, even before the clinical trial stage, it'd be great for some of these networks to just add even in questionnaires and data points about cannabis use adjuvant, right? I am very sure many of these clinical trials, you're going to still have that same, secrecy and people still maybe using cannabis products outside of a trial. So I wonder if maybe we can chat offline about advocating that we all start collecting the same few cannabis data points in order to create some sort of pharmacovigilance networks.
Within the children's long-term and life-limiting conditions arena, we call that hospice care, and it goes broader than a location you go to at the end of your life within children's. And I'm afraid I don't know how the setup is in Canada. There's a lot of data that's been done and a lot of surveys that have been done around what are people using and how are they using it. And we're seeing probably the same as Rod was suggesting, that maybe 30% of those patients that have a life-limiting condition are using some form of cannabis-related product with a little bit of softness in the survey to try not to get our social care and police overexcited, but to understand what we're doing and what's actually happening out there.
Well, thank you so much for joining us today. I know you have to head off a little bit early, and as does Dani, because it's getting late over in the UK. So before you go, Dani, I just wanted to ask you. We're going to talk a lot more about some guidelines and education and that kind of thing. But in your perspective as someone who sees this this space now in the UK, what do you think would be, one thing that you would like to see change in order to sort of reduce harms and increase discussions around medical cannabis in children with cancer?
I'll just echo what's already been said is, bringing it more out into the open so parents feel that they can at least have these discussions. One of the fears in the UK, as well as for children with epilepsy whose parents are desperately seeking assistance where drugs have failed, is that if they try cannabis, they'll have their children taken away. And these are excellent parents. Can you imagine the trauma of having your child taken from you who is sick, who needs their parents, when all you're trying to do is give them a medication that you feel might helping them when everything else has failed. So I think that is where we need to start. And certainly we need more research after that. The tricky part being, as Bob will know, is that when we use these full spectrum products, which tend to work better, but also present so many problems in a randomized placebo-controlled study design. So there's a lot to sort out there, but we need to try our best to get the best research we can and start breaking down it by cancer type as well.
Yeah, and I think a great point about the full spectrum products is like, what's in those products? And I think how we ask people about cannabis, like, it really can't just be a yes or no anymore. It's not that helpful. So I would argue that unless we're asking people, like, what product are you using? Are you smoking it, or are you cooking it in a crock pot and then eating it in a brownie? Because we know that same plant, that same amount of plant is going to have a different response. And so I think that's certainly something that would be called, consistency in how we collect data and all of the challenges of studying the full spectrum products in clinical trials. I am living in the real world here in Canada, where we are trying to get trials with full spectrum products up and running, and happy to talk about some of those challenges in a different webinar. But thank you both so much for joining us, and feel free to contribute and stay as long as you can, but I acknowledge that it's getting a little late. So if you have to leave us, know that a thank you will be coming in your inbox as well. I wanted to talk about the next question I had. I think maybe I'll ask Tracy first. Spins off of what Dani was mentioning about reasons why people might not want to talk about cannabis in pediatric oncology. And so I think that one of the things that we've certainly heard from parents, and we've actually had some discussions with our ethics boards around what happens when parents are using cannabis without a medical authorization, and how can we promote, I guess, disclosing that parents are using cannabis, but also protecting parents and making sure that they have, they know that what they're saying, what implications that might have. And I don't know, Tracy, if you wanted to talk a little bit about how we can sort of promote disclosure without a fear of apprehension.
Yeah, thanks, Lauren. These fears are real, and what's in the best interest of each individual child is really up for interpretation. And as Rod was mentioning, there's, in BC is quite a lot more liberal than maybe if this was happening for a family elsewhere in the country. And then I'm not even too sure about the UK. So unfortunately, there isn't really a concrete answer to this question, or most of the questions that we're answering here today. But I think for marginalized and vulnerable individuals and populations, these fears are certainly rooted in their deep trauma histories with institutions such as healthcare. And historical and ongoing stigma for sure impacts clinical communication, and it further highlights health inequities and further marginalizes these vulnerable populations. So, before I discuss this question further, when I was reflecting about it, I just want to outright acknowledge my privilege. I'm a middle-class white woman who works in healthcare. And so as a result of my privilege, along with the belief that what I was doing was what was best for my child after much analysis, I myself never feared involvement with Child Protective Services. I did worry about what it said about me. I was concerned about the stigma medical cannabis carries and how my choice may impact my professional credibility and reputation. So I had an internal battle going on with me for a long time, circling around how can I provide treatment for adults struggling with substance use, but also be okay with giving cannabis to my kid. In terms of parents not wanting to say things if their kid's on a clinical trial and they may worry that their medications may be taken away. My son's first chemotherapy protocol was a clinical trial, and I did make that assumption that he would be disqualified from the trial if we started to provide him with cannabis. So perhaps one of the oncologists can speak to this concern afterwards, because I actually still don't know the answer. Fortunately, my son experienced minimal side effects while on the trial, so we never had to cross that bridge. It was on his second chemotherapy protocol that I mentioned before that we started cannabis as an adjunct to help him manage the side effects. And his third chemotherapy protocol was actually another clinical trial, but by that time, his team was already well aware that he was taking cannabis, and it never came up as an issue. In terms of promoting disclosure, the reality is there's just so many things that patients and families don't tell their physicians, regardless of what area of medicine we're talking about. So to promote disclosure, I think it really begins with clinicians examining their own personal biases and ethical baggage when it comes to cannabis, and meet people where they're at. And it's through that open, honest, transparent communication where physicians really help families to understand that they're partners in their own care and in the care of their child. And the more information that they're going to provide you with, the more you can help them. So in order to work together to achieve any common goals in any relationship, you need to develop trust, and trust takes time to develop. It's best developed if you park your own agenda, you listen actively, you validate the other person's experience, and you convey compassionate understanding. And I know many families still feel a lot of judgment, and that's coming from the stigma. Transparency is important. And that might look like the doctor just outright disclosing their lack of knowledge about medical cannabis. It may involve referring patients to a physician who has a better understanding of medical cannabis. And these situations and conversations are all going to be highly individualized, like the relationships they're occurring in. Yeah. So until we have the research and the evidence can speak for itself, we need to remember in this gray area we're in now that we're just all trying to do our best. And in terms of child protection, like, everybody is putting the best interest of the child in mind. The child is the top priority, whether it's the family or the healthcare provider. And I really don't think that parents are making this decision lightly or these decisions blindly. There's just that kind of lack of clinical support to come up with how to do things best right now. Cannabis has been authorized for medical use in Canada for 20 years now. And understandably, we know that recreational cannabis effect is not great for a developing brain. So when talking about medical cannabis, it's far more complex to make these decisions for minors, but in healthcare, in terms of disclosure, we should be honoring autonomy, and children in Canada, once I believe they're over 7, they can provide mature minor consent. So a lot of children know that this is my medicine and it's helping me and I feel better when I take this medicine. And as parents, we are the substitute decision makers for our children, not our healthcare providers. So in order to provide family-centered care, we need to have respect for the values and the belief systems of patients and their families whenever possible, and respect this right of parents to make decisions for their children. Healthcare providers, in order to be truly collaborative with families, need to acknowledge that power imbalance exists. And so they should be fostering a sense of self-efficacy, self-determination, and personal control towards the family. And really, like, looking at the big picture, I think we should be spending more time asking ourselves, like, how are we going to balance providing this safe care and be family-centered? How can we best maintain the desired quality of life for children with cancer? And if cannabis is being used as a medication to treat symptoms, or it's being used in addition to conventional medicine in cases with doubtful prognosis, that's where our focus should be. The priority should be finding out, like, what else is needed to help this patient and family during this extremely challenging time? Why have they resulted to coming up with their own medication plan? So for it to be a true child protection concern and family services to be involved, I believe there needs to be an additional safety concern outside of the provision of cannabis as medicine. And in cases like Rod mentioned, where parents are providing large doses, which are causing some obvious harm, or providing some products from a garage that may have solvents in it or be perceived as unsafe, that's where harm reduction comes into play. And those families need some education before we start sounding some alarms. And let's not forget, like, going back to the previous discussion I was having, like, if it was easier for parents to obtain authorization for medical cannabis, and the institutions where these children are being treated were permitted for the physicians to use their own discretion to provide this authorization, then less parents would be out there winging it on their own, or receiving peer-to-peer advice on dosing or how to distill these oils and make them in their garage. It sounds provocative to say, but I believe the medical system is failing the families who feel forced to obtain cannabis for their children with cancer from the recreational or illicit market, when there is a strong medicinal market out there. And we protect parents in healthcare by partnering with them to be their allies in caring for their sick children. So we need to find a way to strike a balance between being concerned about protecting children and facilitating access to families' desired therapies.
Yeah, that's, I mean, so many great points, Tracy. I don't think I need like a whole half an hour just to digest all of the amazing things that you've said, and you've hit the nail. So many great points about protecting parents by partnering with them and by building education. And that's one thing that we've sort of had as a guiding principle of C4T, is we're here basically because, you know, parents and doctors came to us, me from both sides, and said, I don't know what to do. And how can we come together to answer and provide, you know, support in respecting people's decisions? I think these are questions that we'll be answering in the next few years. Matt, I wonder, in the UK, are there the same? I know there's some discussions about UK scheduling cannabis. I wonder if you could just add on if there's any differences here in Canada. As Tracy mentioned, like, there has to be a serious risk of harm to involve child protection services. I don't know if you want to speak about that in the UK.
Yeah, again, it's very similar to what Tracy's just saying, in that, you know, I wish the UK had that harm reduction approach. Unfortunately, it's not there. So at the moment, you know, MedCan is this interim. We're the ones that families go to, we're that link to the clinicians. We can ask clinicians behind the closed doors, so to speak, and get their advice and guide parents in epilepsy and cancer in, you know, dosing regimes, and the safety element of it as well. Is, you know, here in the UK, parents are going to the illicit sources, even for epilepsy. Cancer, that is their only option. You cannot go to a clinician. You know, very few have discussions with their clinicians. They're very afraid to opening it up because they are either growing or going to the illicit market, to drug dealers to source their cannabis. And that comes with a prison sentence here in the UK. You know, parents, I know families that with epileptic children, they've used illicit THC in conjunction with over-the-counter CBD oils. And social services have been brought in along with the police, and potential prosecution against that parent. The child has potentially, their care has been removed from the family as well. It's crazy. So those in the cancer world, it's incredibly worrying for them to, you know, their child is palliative or, you know, a terminal diagnosis. They're going to do everything in their power to help them, and cannabis is known about. And you know, you showed a picture in your introduction of a mother here in the UK. She's very well known. Her name's Candy Blackwell, and yeah, she gave her son. In fact, it's my local hospital, Norwich Hospital here, and she gave her son cannabis on his deathbed. He's given 3 days to live. And that miraculously just turned things around, and eventually she came out and said about, you know, her use in cannabis. And only the other day, MedCan Support, we on our Instagram posts and social media, we spoke with her family. Their son James, he had DIPG. Now he sadly passed away 18 months ago, but he was given 6 months, and through the use of cannabis, that extended his life to 4 years. And you know, his quality of life was so much better. He had no side effects from the radiotherapy, and he was able to go to school and live this really good, great life. But his mum and dad were growing the cannabis. They had no support whatsoever from the hospital, from the clinicians. They kept it completely hidden. They spoke about, you know, they really wanted to say it, but they're just so worried about the concerns from, you know, or the police and social services, etc. So yeah, this in the UK, we have to change this narrative. I really feel that clinicians should be stepping out, you know, ignoring the stigma and starting to learn about cannabis, and actually taking data from families, understanding how they're using it, why they're using it, and, you know, like Rod said earlier, is collecting data. That just simply isn't happening. You know, the UK trials are a long, long way off, even in epilepsy. We don't have domestic supply other than GW Pharma, and they're only concentrating on isolates in epilepsy. So until we have UK domestic supply, we're reliant on imports, which are hit and miss. Clinicians in the private sector are not prescribing for cancer in pediatrics. So yeah, and sadly, our families are left in the dark and in the shadows, and that's why MedCan, and you know, speaking with you guys, I think this is the first webinar that I've seen openly talk about cannabis in the UK for pediatric cancers. So we need to continue this narrative, bringing in more oncologists and start breaking down stigma.
Yeah, that's exactly why we were really, what brought us here today is to start having these discussions so that, you know, both clinicians and parents don't feel like they're alone in navigating this uncertainty. And Sapna, maybe you can speak to, you know, we talked a little bit about supports for parents and sort of the landscape for physicians, but what do clinicians need? Like, as an oncologist, what kind of support do you need to learn more and to advocate and to, you know, understand and feel more confident in medical cannabis authorization?
Well, I think it's like any other medicine, right? So we have to start like what is me here is like usually traditionally we'll start from, as Bob was saying, you start from the petri dish, you go to the mouse, and then you go to the phase 1 trials, 2 trials, 3 trials, and real world. That's how the trajectory of any new drug is. But here we are doing it reverse, right? Because the real world is outpacing the research. So we are going backwards. So which I think that we have to still need to have some evidence-informed policies. We know, acknowledging that we do not have a great evidence, but at least for whatever evidence we have, how we can support our patients the best. And I really like the phrase which Tracy mentioned, like open, honest, transparent discussions are very important, and approaching the patient with a non-judgmental approach is important. And again, kind of having those educational sessions with oncologists, like how it's important to bring in that harm reduction lens. And again, the ones like Rod, who has years of authorizing cannabis, he still uses that approach, right? He's not going to say that, oh, there is a role, you got to, like, we are going to do this because it's very effective. You're still informing the patients what are the harms and what are the potential benefits. So I think and we all oncologists have different perspectives, but I think creating those webinars like this is important. Going to the oncology organizations like cooperative groups, which we have in North America, in Europe, and that's also important. Supportive care groups is important, and creating evidence-informed policies, and also providing the pathways, how to authorize, what to authorize. Like, I mean, walking through those clinical care pathways is important as well.
And I think that's where, at least in my perspective, I think it gets a little bit different than a traditional medicine, right? If you prescribe even nabilone compared to a full spectrum product, you're prescribing 1 milligram twice a day. That's what they're going to get. When you're authorizing cannabis, you're going to submit it on medical authorization form, and then it's sort of up to the parents and the licensed producer to figure out what product that might be. And so the system here in Canada isn't set up that what you authorize is like for sure what they can get, for many reasons. The company may not have that product anymore. They may choose to go to a different licensed producer. And so I'm imagining that that's where some of that uncertainty comes in as well, as with the medical authorization. It's just not quite a prescription in terms of like the level of detail that you can sort of, you'll know if they fill it. You know, you can get that information on if that drug was filled, how often it was filled. And we can learn from administrative health data. We can look for long-term health outcomes. We did get a question from Slido I wanted to answer just before I ask everyone here for sort of their last comments, which was about, are there any physiological effects of cannabis on the pediatric patients even as they grow older? And this long answer to that is, well, really, we're not very sure. Lots of things have adverse effects in children, and lots of the medications that are used in complex pediatric cancers have long-term side effects. And obviously, you know, we just don't have that data to support. We don't even know if it's going to work in the short term, let alone what the long-term effects are. It's going to take us a long time to answer those questions. In terms of like the literature, there is some literature about recreational cannabis. Again, this is, you know, typically THC, typically smoke, typically, you know, not a controlled daily dosing, that can suggest that there are potentially increased risks of earlier onset psychosis in those who have family histories of psychosis. But in terms of like physiological changes, there's really not anything documented. But again, this is a space where we're going to be learning a lot for many years to come. So not really a clean answer to that question, but thanks for asking it. So I just wanted to be sure that we heard from each of you one last time. And I think, you know, every time I have these discussions, the underlying comment from everyone is we need evidence. So you're not allowed to answer, we need more evidence, because we know that. But also, you know, kids with cancer can't wait for the many, many years and funding cycles and amount of investment it's going to take to have RCT data on cannabinoid and cannabis-based medicines. So what I want to hear from each of you is, what is like one actionable change that you would like to see that could reduce harms related to cannabis use for medical purposes among children with cancer? So I think maybe Matt, we'll go to you first.
He disappeared.
Oh, sorry, I can't see that. Then maybe Matt, we won't go to you first. Tracy, we'll go to you first since your mic is working.
Thanks. An actionable step, I think, is just whether you're the healthcare professional, the parent, the patient themselves. If anything that we've talked to you guys about today applies to you and you haven't already done so, you need to have the difficult conversation about medical cannabis, or keep that conversation ongoing. And I think it's important to remember it takes courage and vulnerability for families to approach this topic based on a lot of the concerns Matt and I have already talked about. So having the difficult conversation, I think both people need to come to the conversation with an open mind and room for collaboration and flexibility, and a spirit of curiosity. Every family might be doing this for a different reason. And in dialogue and relationships, people don't always agree. And it's important to remember that that's okay. And I love quoting Maya Angelou, and I think she brings a lot of wisdom here when she said, do the best you can until you know better. Then when you know better, do better. So when it comes to medical cannabis and pediatric cancer, I think that's what we all need to be okay with doing right now. It's just, we're going to do our best, and then we're going to find more out, and then we're all going to do better. So I'm hopeful that conversations like we're having today, the healthcare community will begin to increase their acceptance of at least talking about cannabis and the therapeutic uses for oncology. But the regulations to study cannabis are continuing to stifle the research. So I think that it's going to have to be partnering like we are right now, parents with healthcare professionals, to help remove those barriers to research, because we can't really do much without the data to inform the care that is being provided.
That knowing better, right? How are we going to know better if we're not collecting data in a rigorous way, and we're not all calling, cannabis the same things, and we're not looking for answers right now. And so, yeah, those are great points. Rod, what's your take here? What's an actionable change that you'd like to see?
Yeah, I think to build on what Tracy has kind of hit the nail on the head on a few things perfectly. And I think we have all these N-of-1 experiments happening, but we're not actually capturing the data on all these N-of-1 experiments. And so again, I think that's one thing with C4T, I think we're trying to do, is to actually capture that evidence for each of these, single patient experiments that are happening coast to coast. Let's capture the data. Where is it working? If it's not having, we hear about the anecdotes of these miracle cures, which are amazing, but I can tell you, I've treated a lot of palliative kids where it's had no anti-cancer effects, but nobody publishes those negative things, and so you don't actually know the data unless, and what tumors is there a signal in? You heard about DIPG. I've seen some great long-term living longer with great quality of life in DIPG compared for some kids on cannabis products. And so again, we need to study that and capture that data. And I've got anecdotes, but we need to actually collect anecdotes scientifically. So I think that's the first thing. And then the other thing Tracy just mentioned was kind of one of the key points, that is clinical trials of rigor are super important and need to happen. The problem is this is a medication that families can access. Typically you're dealing with clinical phase 1 studies of drugs that you can't get unless you go on that phase 1 and study it. The horse is out of the barn. Parents can access it, and it's easier for parents to go down that route. And so we have to do the scientifically well-designed clinical trials, but the regulation has to look at the fact that parents can access this whether they're on a trial or not. And so we really need to actually say, we need to study, we have to study it, and some of the barriers that are there have to be brought down. And the other thing I hear in the pediatric space, well, it needs to be studied in adults first. Well, again, these are drugs that kids are being exposed to daily in our clinics. And so, no, we don't need to do phase 1, phase 2 studies in adults first, because kids are already on it. It's not like they're going to end up on it in 5 years later. And so I think, again, it's changing the mindset of some of the hurdles that we face, trying to actually study it in a prospective, randomized way. Those barriers have to be broken down, and I think it's with parent advocates and ongoing discussions with regulators that we have to explain that the parents are using this daily, and we need to break down and get properly designed studies done in a different way.
Absolutely. And on that note about regulators sort of advocating that, if this hasn't been studied in adults first, I mean, unless you've never met a teenager, like, they already make their own decisions about cannabis. So awkward to just sort of close a blind eye there. And one point I wanted to talk on before I turn it over to you, Sapna, is clinical trials, right? So now it's looking like, okay, 20, let's say even 21 and 5, let's say that number holds across Canada. 20% of these kids are on cannabis. Like, shouldn't we be asking all kids in all the clinical trials, given the potential for drug interactions? Have you seen either Sapna, Rod, Tracy, I'm not sure if you're still in any trials, are any of the trials collecting this data, or is it just like, does the kid use other substances and maybe that's cannabis?
No, it's not in any trials. And I sit on the REB, so I see a lot of trials coming through in other spaces. The only group that actually asks about this and has methodology built in is the neurology trials are now actually addressing this, because so many of their hard to treat epilepsies are on cannabis products, where they essentially mandate that you have to be on a stable dose for a period of time before you go on their trial, which is, I think, a good way of doing it in a situation where you have a large proportion of the population who are on it. Is you have to be on a stable dose. And we do that in oncology for steroids, like, for certain things, you have to be on a stable dose, not going up or down, and then you can enter the trial if you've been on a stable dose for 2 or 4 weeks. So that way you can kind of try, but again, this drug, the trials get messier, but no, like our big phase 3 trials aren't capturing it, and there may be drug-drug interactions or ADRs or adverse drug reactions that are happening that we are. So
maybe one of our call to actions for all the non-cannabis researchers out there is that please just collect some rigorous data. If you have questions about how you should ask, just please contact us, because we should be ensuring that all clinical research in pediatric oncology from here on out, we want to learn how to do better, and we're not going to do that if we're not asking. So some great points there. So Sapna, what are your thoughts? What's an actionable change you'd like to see?
Well, I think Tracy and Rod have already highlighted most of the things which I would like to say, but I also want to say that as you asked, Lauren, that the trials which we are doing now probably will produce data in 10 years. So what do we do in 10 years? So I think as we always do as a clinician, use your risk-benefit calculus. And that's important. Like if a patient who is having a chronic pain and is palliative, that's a patient, right, in which probably there is much less risk, but probably there will be benefit of cannabis, and helping that family, having those discussions and providing them various routes through which they can help, and they can feel supported in their decision making is important. And again, not every, like in our practice, I wanted to say that not every pediatric oncologist have to learn that to like Rod to authorize cannabis. It's still there are doctors which are there, like we have a which Lauren knows, we have a pediatrician who has a lot of experience in doing cannabis. So in some of our patients in which we think that there is a value in using, we do refer our patients to her so that they can have access to an expert who uses cannabis routinely, right?
Who can help just with the comfort level, right? And I know we talked about filming a video of just parent and clinician interactions, and just maybe even having some mentorship for clinicians, and or even phony discussions. There's lots of simulations that happen in medicine and medical training, and maybe what we need are some simulated discussions about how to sit with your bias and your uncomfortable, your uncomfortableness. Sorry, Tracy, did you want to add one more thing?
Oh, it just cued me when Sapna said about decision making. I think that it would be really handy to have a streamlined sort of decision making tool in terms for parents, risks, benefits, and same with healthcare providers. If they are able to provide authorization, then a decision-making tool, algorithms, maybe for separate departments, but having some sort of something where you can go, oh, okay, so this is this and this is that, and I don't know, at least cueing people to ask the right questions or think about the appropriate risks.
That's a great point. Almost like a discussion guide of for parents on parents and clinicians and parents and clinicians, kind of a peer-to-peer guide. I think that's something that we could definitely work on internally and with this group and everyone on the call today. Thank you, all of you who stuck around, and all of our European friends who it is getting very late for them over there. And thank you to everyone who logged in today. Thank you to MedCan Support for sharing about our webinar, and all of our panelists for lending us your brains and your time and your expertise today. Just a reminder that this webinar was recorded and it will be available on our website, which is www.medcankids.ca, and it will be posted on our YouTube channel. If you wanted to learn more, I'm just going to share the screen for one last minute here to say a big thank you to all of our partners and our steering committee, our youth advisory committee, our parent partners, all of our members, all of our funders and partner organizations. There are many, many folks behind the scenes at C4T that make these webinars and a lot of our research happen. And so I just wanted to, again, thank everyone for tuning in today. Our website is available there. And at any point, if you have any questions or you wanted to learn more, or you're an organization that wants to collaborate with us, please feel free to send us an email at c4tcanada@gmail.com. And so that is it for now. We hope you enjoyed today's discussion and you join us for another webinar again soon. Thank you.